Hello and welcome to this episode of sMater, a podcast by clinicians for clinicians, brought to you by Mater, an Australian leader in healthcare for more than a century. My name is Gillian Whiting.
And I'm Catherine Cooper, Clinical Specialty Coordinator for Mothers, Babies and Women's Health at Mater.
And we're coming to you from Meanjin, the land on which this podcast is being recorded. Today, we are joined by Huda Safa, Senior Specialist in Obstetrics and Gynaecology at Mater Mothers Hospitals. Huda has a wealth of experience in high-risk pregnancies and is dedicated to maintaining a patient-centred care approach. She's actively involved in the medical education of specialist trainees, junior doctors and medical students, and is also a senior lecturer and on the Board of Examiners at the University of Queensland.
Today, she's joining us to talk about preterm births, recognising the risks.
Mater.
Caring for the community for more than a century.
Innovators in health, education and research.
Home to world-class clinicians.
State-of-the-art facilities.
High-quality, patient-centered
Australia's largest and leading
turning
maternity.
scientific discoveries
Educating
into
the nurses,
life-changing
healthcare
outcomes.
advancements and provider.
We are Mater.
We are Mater.
We are Mater.
This is sMater.
Huda, welcome to sMater.
Thank you. Thanks for having me.
Let's set the scene. Who's most at risk of preterm birth?
Risk factors for preterm birth are well published and described in national and international guidelines. And one of the most predictive risk factors is a history of previous preterm birth in the woman herself, but also other risk factors like multiple pregnancy, previous history of substantial cervical surgery like cone biopsy or multiple LETS procedures. These are usually procedures that are undertaken to treat cervical dysplasia, which is encountered in the context of abnormal pap smears. So when a abnormal pap smear is detected, surgery sometimes is required. There are other risk factors largely related to demographics and socioeconomic factors associated with preterm birth, like smoking, for example. But a good percentage of women who develop preterm birth, unfortunately, lack any identified risk factors.
How much attention should we pay to those socio-demographic factors compared to, say, cervical surgery or smoking?
That is a very good question, actually, Catherine, and the evidence doesn't exactly tell us the weight of each risk factor that is associated with preterm birth, but I believe the focus should be on what we call modifiable risk factors, and definitely socioeconomic factors are in that category. You cannot do much about previous cervical surgery risk, or risk I did not mention is risk of congenital uterine abnormalities or Mullerian abnormalities. There's not much that can be done about that. But definitely investing in modifying risks such as smoking early in the piece is such an investment to reduce a range of perinatal adverse outcomes, not just preterm birth, and of course goes beyond pregnancy years. So I totally agree. We should focus there.
What about women who don't tick any of those boxes that you've mentioned there? How then do you identify risk?
That's a brilliant question, Gillian, and actually the subject of a large national collaborative aiming at reduction of preterm birth. So a good percentage of women, like I indicated earlier, will lack risk factors and have a short cervix incidentally found at mid-trimester scan. We believe we can target that cohort of women to make a difference to preterm birth risk in this country.
So when do we do that scan? Is there a strict window for when you do that?
So this is a scan that is also known as a morphology scan. So it's the main ultrasound scan that most pregnant women will choose to have during the journey of pregnancy. And that is usually performed between 18 and 20 weeks. And the evidence for the purpose of reduction preterm birth is strongest for that window, if you like. So if we identify short cervix in that scan, that's an opportunity to intervene and prescribe progesterone to reduce the risk of preterm birth. Because a short cervix, even though incidental, i.e. there's no symptoms, is a powerful predictor of increased risk of preterm birth.
So once you've identified someone as being at risk, what conversations or what support do you give those women, particularly around those who probably may not be expecting it?
Yeah, that's a very good question. I think the conversation should start before we identify the risk, especially in the context of those women in whom a short cervix is identified, by educating them, because women do expect to have that morphology scan around that mid-trimester, and we need to explain to them that measurement of the cervical length is routine part of the ultrasound scan, and there is a possibility that the cervix might be identified to be short, and if that's the case, they need to either present to us at the hospital where we can address that and start progesterone therapy, or go back to their GP as soon as they can to get that support and follow-up programs in place to try and make sure that we have a cervical surveillance program for them.
So education is key, and helping them feel safe and that there is a clear pathway.
Exactly right. So there's no unknowns or mysteries or surprises, so clear communication pathways.
In a best practice statement reviewed in 2021, RANZCOG, the Royal Australian and New Zealand College of Obstetricians and Gynaecologists, supports the use of transabdominal screening of low-risk women with singleton pregnancies at the mid-trimester scan, with additional transvaginal assessment for those with a short cervical length or a full cervical length unable to be clearly viewed.
Let's talk about that in a bit more detail, please, Huda. So women who go through that midterm scan, as you mentioned, the morphology scan, which they're familiar with, where the cervix is measured transabdominally, how long should that cervix be, and at what point does it ring alarm bells for you?
Yes, that is the new message we're trying to get through to our sonographers, radiologists, and women themselves, is that the cervical length is usually measured on abdominal modality, transabdominal modality. And if the length that is measured is less than 35 millimeters, or indeed the cervix cannot be clearly visualized, that is when the next step is indicated, which is offering that woman a transvaginal ultrasound scan to get a more accurate look at that cervical length. And the cutoff value that we look for as significant is less than 25 millimeters. So a transvaginally measured cervical length of less than 25 millimeters is defined as short and requires an intervention, ideally that same day.
How did we determine that length of 25 millimeters?
So very good question, Catherine. The 25 millimeters seems to be the cutoff where the risk prediction matches a lot of studies that have been done in this space for intervention, and it matches the shortest 10th centile of what a cervix should be in mid-trimester.
So some women, I assume, would not be prepared for a transvaginal scan. Does some say they're uncomfortable or refuse even?
That is, I think, comes down to lack of knowledge of the role of this, let's say, intrusive examination for some women. And that's why part of our collaborative at MATER to reduce risk of preterm birth, we produce some patient education brochures about cervical length for education. I personally have a conversation with women about their morphology scan and say that this is a detailed ultrasound scan that has three objectives. One is assessing your baby. One is looking at your placenta and its relationship to the uterus. And one is to look at your cervical length. And in a small percentage of women, it will be short on transabdominal modality, and that needs to be checked on a transvaginal modality. In fact, there is evidence to support a high level of acceptability in the population when women are educated and expectations are set about the role of this test. They appreciate the diligence and the care that's provided to them to identify a risk that is mitigatable.
Huda, what happens if the woman does decline the transvaginal scan? Like, what are the options available to the clinician? Like, transabdominally is not as clear as transvaginal?
The transabdominal modality does have pitfalls and limitations because usually performed with a full bladder and pressure with the probe on the abdominal wall, which can falsely elongate the cervix. And again, backed by evidence, when you eliminate these factors, because for a transvaginal modality, the woman needs to empty her bladder, and the probe is different. It's entered vaginally, so it looks closer at the cervix, and it's, if you like, the source of truth. If a woman does decline, we always maintain patient-centered care and uphold the principles of respecting patients' autonomy. We then shift and focus from approaching this in proactive, prophylactic way to a more reactive way. Should a woman present later on in pregnancy with symptoms suggestive of preterm birth, contractions, pelvic pressure, we then use transvaginal ultrasound scan for cervical length assessment as our diagnostic tool to say you have increased risk of preterm birth in the next 7 days, and then there's a different protocol to try and suppress contractions, start steroids, antenatal steroids on board. So we always try and approach things in a proactive way, but I respect some patients might have different reasons for declining a recommended intervention.
We go into more of this in future episodes, but can you go into a little bit more detail about the preferred methods of intervention when someone with preterm birth is identified?
Yes, that is also a very good question. What is available to us and backed by evidence is 2 interventions. The least invasive and associated with no known harms or risk is vaginal progesterone. Natural vaginal progesterone, started on that same day that a short cervix is identified, has been proven to reduce the risk of preterm birth. And that's the preferred first-line option. This is in the context of a woman who's had a short cervix identified at mid-trimester scan. The other option is an operation called cervical cerclage. It's a surgical procedure under general anesthetic or spinal anesthetic where a stitch is placed in the cervix, a permanent stitch that's usually removed 36 weeks to support that structural integrity of the cervix. As you might appreciate, it's a more invasive approach, so it's not usually first line, but there'll be a select group of patients for whom it might be an appropriate first line. For example, a woman who's that comes to mind who is started on progesterone, and despite that, there's progressive cervical shortening that we would detect with the surveillance program I was talking about before. In those women, a stitch indicates probably a more appropriate option. Another scenario where a stitch is an appropriate first-line option is a woman who had previous history of, sometimes more than once, of preterm birth or second trimester loss. In those women, a cerclage is superior to progesterone as an intervention. There are obviously many other interventions that have been studied and are not really backed by evidence, so we don't tend to use them.
A major risk factor for premature labour is being pregnant with multiple babies. The Australian Bureau of Statistics reports that in 2021, mothers who had a multiple pregnancy accounted for 1.4% of all women who gave birth. Queensland and the Australian Capital Territory had higher proportions of multiple births than any other state or territory.
When we're talking about women with multiple pregnancy and the risk of preterm birth, what is the rate? How common is it for those particular patients?
Oh, multiple pregnancies is a different kettle of fish altogether. Yes. In fact, if you look at our statistics from Queensland, our preterm birth for multiples in 2021 QMPQC report was as high as 69%. But can I say only a third of those were spontaneous preterm birth? It is important to acknowledge that about 20 to 30% of preterm births are iatrogenic, initiated by us because of a risk that's been identified to either the mother or the baby. And unfortunately, in multiple pregnancies, depending on the type of twins, which are the most common type of multiple pregnancies, there's so many other risks that prompt iatrogenic earlier delivery. So they have multiple pregnancies, to answer your question, Julian, have increased risk inherently of preterm birth, both medically indicated and spontaneous.
You mentioned progesterone and cervical cerclage. Are they suitable for multiple pregnancies? Can we use them?
Yes and no. So if it's an unselected multiple pregnancy, i.e. there's no previous history of preterm birth, there is no short cervix in this pregnancy, using progesterone prophylactically has not been successful in reducing the risk of preterm birth in this cohort. However, if you have a multiple pregnancy with a short cervix, absolutely, progesterone and potentially cerclage in some studies and not others has been effective in reducing the risk of preterm birth.
One of the risk factors for preterm birth that we haven't discussed is infection. What infection are we talking about?
Yeah. Infection and inflammation were actually some of the earliest risk factors that were studied in this space. And yes, of course, there is systemic infections like the flu and COVID and pyelonephritis. Any maternal systemic serious infection could start a cascade of preterm contractions and preterm labor. But I guess in this space, we're talking about localized infection or probably even colonization of the genital tract with some bacterial species that are not strictly an infection, although can be associated with some infections like STIs, that have been in older studies associated with increased risk of preterm birth. The problem with looking for infection routinely is that the results of studies have been conflicting about effectiveness, especially in asymptomatic population, going and screening all women for the risk of presence of some bacterial species in the vagina for the purpose of giving them antibiotic treatment has not been effective in reducing preterm birth. However, we do screen for other infections. For example, asymptomatic bacteriuria. We routinely perform a urine test for these women to reduce maternal disease and risk of infection transmission. So there are other areas where we do screen routinely for infection, like syphilis, for example, to reduce some risks, but not on population basis.
So one of the things that I'm personally passionate about, obviously, midwifery continuity of care. I understand that can make a difference to outcomes.
Absolutely. Absolutely, Catherine. In fact, it's one of the core 7 strategies of the Preterm Birth Prevention Collaborative is that women should have access to a known midwife throughout their pregnancy if possible. And we are very lucky at Mater that we do offer continuity of care to a variety of our pregnant population cohorts, including Preterm Birth Prevention Clinic now. I think we have at least 2 publications from Mater attesting to the value of continuity of care in both of these 2 populations. One is a First Nations woman, BIOC, or Birthing in Our Community model of care, and the other one is young women. So that's another high-risk group for a number of adverse perinatal outcomes. So these 2 studies have both demonstrated reduction in preterm birth rate when there is a care by a known midwife. So that is some of a larger pool of evidence there. So that's undebatable. In my mind, at least.
That seems like good news for you. It makes you very happy.
It does. It does. Before we go, Huda, we'd like to introduce you to a little segment called The Checkup.
So we want to know more about Huda, the medical professional, and Huda, the person. So Catherine's going to ask you 5 quick, very simple questions. Are you ready?
Yes.
Okay. How do you want patients to see you?
How do I want patients to see me? As a caring, compassionate, supportive, and approachable doctor.
Beautiful. How would you describe your handwriting?
Oh. Can we not?
Okay, moving on. Who was the last person you FaceTimed?
My dad.
What TV show best portrays your profession?
Oh, Grey's Anatomy.
Oh, come on. Where all the doctors do all the nurses' work.
But it is very unrealistic. Look, to answer that question, most medical TV shows don't reflect the reality that we live in. But I thoroughly enjoy watching.
It's such a good show, though.
Grey Anatomy.
And what's your superstition?
I don't have many. Yeah. No, I just take it as it comes.
Beautiful. Huda, thank you so much for joining us on sMater. That was fantastic.
Thank you for having me.
For our listeners at home or in the car or having a well-deserved break between patients, thank you for tuning in. See you next time on sMater.